We're going to start by looking at how the change in regime will affect the very young. It's allergies that trigger medical intervention in this age group and pharmaceutical recourse to what are called elemental formulas. So what's changed? Well, in broad terms, the new arrangement expands the base of those authorised to prescribe beyond specialists and to GPs and dietitians. Note that this expansion of prescribing authority applies both to the needs of the very young and to the elderly. Lactose-free soy and goat's milk infant formula will no longer be funded. Those infant formulas that remain on the list will be fully funded, no more surcharges. A new funding pathway for elemental formula has been adopted, a sort of ladder which, with a few specific exceptions, requires prescribers to trial hydrolyzed formulas before moving on up the ladder to those much more expensive amino acid formulas. Patients will be reassessed every 6 months to determine if a less specialised formula can be used. Now, to explain the changes and the reasons for making them, here's PHARMAC's Medical Director, Peter Moody.
Special foods on the pharmaceutical schedule has been an area of growth for many years. It's a confusing area because although it's on the pharmaceutical schedule, it looks like a medicine, but really it's a food. However, we spend about $18 million a year on that, and the growth in some parts of that is very significant. For infant formulae, the growth is about 30% per year. For those adult foods, those high-calorie foods, the growth is about 12% per year. So it's an area that really does need to be rationalised. What we've done in the first instance is to look at who can prescribe these. In the past, it's been only certain specialists who have been able to do that. We think that that is unfair, and unfair both to those people who need to use those medications and those who need to prescribe them. So what we've done is we've widened access to authorising these prescriptions to two extra groups. The extra groups are general practitioners who are vocationally registered. That means that they've got exactly the same status as any other specialist. And we've also added dietitians who have got special prescribing rights. What we've done with the infant formulae is that we have now made the decision to fully fund them. However, there is a series of steps that you must take in terms of which formula you must use first, so that the least expensive is used first, the most expensive is used last, and we estimate that there will be very significant savings by doing that. As far as adult formulae are concerned, we have made them fully funded, but that is for the powders as opposed to the liquid. So if you want adult sip feed, what you can do is you can prescribe them as the powder. They will be fully funded. If you want the liquid, there may be a part charge, and that's up to the manufacturer. However, with the adult feeds, what you will find is that there are now some logical steps that you must take before you can actually have fully funded access to them. We have what is particularly called a malnutrition index, and you will have to make sure that your patient qualifies under those circumstances. The final point I would make is that there are some foods which are extraordinarily expensive, but also for very rare conditions. These people, either they're children or adults, will die if they don't have these particular foods, and these remain fully funded. There's also, finally, a small group of particular diseases that we've said that you don't need to have specific criteria for. Things like cystic fibrosis is an example. And so the rest of this program will be discussing these issues in more detail.
Peter Moody, Medical Director of PHARMAC, with his summary of what's changed in the prescribing regime. In a moment, we'll be discussing the whats and whys of the new arrangements, specifically as they apply to infant formula. Dr. Moody is with me in the studio, along with Professor Murray Tilliard, a general practitioner, Dr. Jan Sinclair, who's a paediatrician, and paediatric dietitian Anna Richards. Now, I've got a sheaf of questions that some of you have sent us prior to tonight's program. I'll add those to my own question line, And we'll also be fielding questions live from the audience who've joined us here at Avalon. As well, we're inviting questions from viewers at home. Text us your questions and we'll try to sew them into the rich tapestry of our debate as we go along. But just before we go to the panel, let's hear from paediatric specialist Pam Jackson.
Cow's milk protein allergy is quite a complicated condition. It's really a spectrum of disease, and so the diagnosis is really straightforward if you have a child or infant that develops welts or urticaria or what we would term hives. That's pretty easy in terms of diagnosis. But there's another range of conditions where the diagnosis may be much more uncertain. The symptoms might be a little more difficult to put together. The child might be restless, might have gastroesophageal reflux, they may be vomiting, they might have diarrhoea, or just be very, very unsettled. And sometimes making that diagnosis and ruling out all the other possible causes of such common conditions can be quite tricky and time-consuming. So I guess the success of these changes is going to hinge on the accuracy of diagnosis of cow's milk protein allergy in children and infants. And it's not always straightforward. Unfortunately, it's not black and white, it's not always easy. It's time consuming, it means you need to rule out a lot of other simple, common conditions that can be managed in other ways. And I guess if you are prescribing a hydrolyzed formula or an amino acid-based formula in that scenario, then that might lead to inappropriate use of that particular formula. So it may not necessarily reduce the prescribing. It might. So the question is, why has there been an increase in the use of amino acid-based formula as a first line? And I guess some of that is to do with people's experience with one particular formula and confidence in that formula. Some of the hydrolyzed formulas do have cross-reactivity, and so you might need to go through a longer process before getting the answer and the outcome for that particular child or infant who's suffering, and consequently the rest of the family's suffering. And so I suppose the fast and easy way is to just start at the top, which obviously is more expensive. So if there's an infant that I suspect has non-IgE mediated dairy allergy, then there are a number of things that I might want to do. If the child's being breastfed, the first thing I'd probably suggest would be for mum to come off all dairy products and see how that had an impact on the baby. You need to wait a good amount of time, 2 to 4 weeks, to see whether there was an improvement. If the baby was being partially breastfed and partially formula fed, clearly you want to change that formula away from dairy, but maybe your first option is to promote full breastfeeding and a dairy-free diet in the mother. I don't think this is a particularly easy area. Sometimes it's worth changing on to a hydrolyzed formula. Breast is always best, and supporting mums in doing that is absolutely crucial. And sometimes it's been a long, hard road with a very sick, crying, unhappy, unsettled baby, and you need to be very, very careful about your advice around just severing that tie of breastfeeding. I think it's important, though, if you're going to be introducing a formula, and you can do that as the baby starts to wean in their weaning foods, to then consider a non-dairy formula, so either an extensively hydrolyzed formula, amino acid-based formula, or if the child's over 6 months, of course, soy is an option as well.
Murray, you heard Pam Jackson there saying that diagnosing cow's milk intolerance isn't always easy. It's not cut and dried, and it can be very time consuming. Is diagnosis of cow's milk allergy an issue that is going to test GPs in particular now that they have these new prescribing rights?
I mean, I think it's actually tested us for quite a few years, and in fact it seems to be becoming more common. I remember in the 80s either we were missing it or it wasn't as common. But there's a couple of questions, I think, from a general practitioner point of view I'd like to ask. And that is, Dan, in terms of the urticarial reaction, obviously we're likely to see this quite immediately. If a parent presents with a child with a reaction like that, do we re-challenge?
Ultimately, the answer is going to be yes, but how and when that's done is not going to be the same in every situation. So if we think that a baby's had urticaria in response to cow's milk, then I would always confirm that IgE is the mechanism. We sometimes see kids who should have IgE to a food, but the urticaria has kind of been a bit of a red herring, so we don't want to institute an exclusion diet for a period of time if in fact the urticaria was due to something else. If you confirm that it was due to cow's milk, then the time frame and how you go about re-challenging really depends on a lot of things. One, it depends on the amount that the child took. So if a child had a little bit of urticaria after a lot of milk, I'm much more comfortable that they could maybe try a bit under supervision or at home carefully in a period of time. If they had widespread urticaria after a couple of mils of milk, then I'm not going to be suggesting that they just give it a bash at home again in another 2 or 3 months.
When you talk about confirmation, what would I do as a GP trying to confirm?
So in terms of IgE, there's 2 main ways of documenting that. The first is by skin prick testing. Skin prick testing's safe, it's simple, it's generally well tolerated by young children, and certainly within the Auckland region, so that's where I practice, skin testing is readily available through community labs. The other option is something called a number of different things, RAS testing or EAST testing. So it's basically a blood test measuring specific IgE. Acts kind of similarly in terms of sensitivity and specificity of the test. It involves taking a blood test, is much more expensive. Pros and cons to each of them, but either one of them would be fine in terms of documenting the mechanism.
Do you see the process of diagnosis as being a complex one?
Well, not for straightforward IgE-mediated allergy. So that's the urticaria, getting swollen, vomiting, sometimes anaphylaxis. The non-IgE-mediated cow's milk intolerance is much more complicated because most of the ways that that presents can also be due to a number of other conditions.
So they can be ambiguous?
Sure, yeah. So you might have a baby who's got reflux and or eczema and or a bit of unsettledness, which might be due to cow's milk, but might be due to something else altogether.